Thanks for the opportunity to present today. So my name is Anna Ibele. I'm an assistant professor of Utah. These are my disclosures that aren't relevant to this talk. But I think my disclosure that is relevant to this talk is I am a bariatric surgeon who also does benign esophageal and anti-reflux surgery. And in that role, I wear multiple hats, as do I think probably a lot of you in this room. And one theme I'd like to carry through this talk today is that when taking care of morbidly obese people who present with dysphagia or reflux, and certainly those who present with achalasia, it's important to wear all of the hats that we have at once when we're thinking about these patients. So manometric abnormalities are very common in the obese patient population. And I think while it's not intuitive, achalasia does exist in these patients. So dysphagia can lead to, as we know, maladaptive eating. And for a lot of people, these are kind of high carb, high sugar, liquid diets. And these diets and our lifestyle in this country are conducive to gaining weight. So in our practices, we may encounter patients who come into a bariatric clinic with a diagnosis of achalasia, or come into an esophageal clinic and are obese or morbidly obese. This is a copy of something fun we're doing at Utah. So we have patients who come into our bariatric clinics and our foregut clinics now who are given a tablet and they fill out a variety of information. And this is the GERD Health-Related Quality of Life Scale that my bariatric patients are filling out when they walk in the door. And if they're telling me that they have dysphagia or odynophagia, that's going to warrant a little bit more discussion when I go in to talk to them about surgical options. So there's a lot of debate kind of in the bariatric sessions now that's really interesting, talking about the utility of or lack thereof of routine endoscopy before bariatric procedures. And I would make the point that for anyone presenting with to a bariatric clinic with dysphagia, this warrants some additional evaluation. We should treat these patients just the way we would if they walk into our esophageal surgery clinics. And while this is even kind of more heated, I would argue that if people are coming in for a bariatric operation and they're telling me they've had a long history of reflux, they've never had an upper endoscopy, I think it's very important to evaluate this patient. Obviously, it's a little bit more straightforward if they're referred into our esophageal clinics for achalasia. They get the workup below. I won't go through this lovely slide that my friend Dr. Garon gave me as well. But really kind of the meat of this talk is, well, what do we offer these people? And so there are endoluminal options, pneumatic dilatation, some surgical options, which I'll go into a bit more. And then POEM is very interesting in this area as well. So one point to make is that as a bariatric fellow, I was taught that, you know, hey, if I meet a patient with a BMI above 40 and they have pathologic gastroesophageal reflux disease and they want to change their lifestyle and get off of their medicines, I should really be offering that patient a gastric bypass. And there are many out there. I think Sage has had a nice survey that John Gould may have published, talking to the membership and, you know, what BMI would you not offer a patient a conventional fundoplication anymore? And I think it's important for achalasia to make the point that this is a little bit different, right? There are patients who have pretty life-limiting symptoms from this disorder who are not interested in a bariatric operation, or they may not qualify because of various comorbidities, psychiatric problems, narcotics or substances. And they still need help, right? So we should still have this discussion with them. And for this population, a Heller is probably a reasonable thing to do. There are some pearls from this lovely chapter Dr. Fischella and Patty wrote that might help us a little bit technically in this area. So in bariatrics, it's very common to put people on a high-protein, low-fat diet for 2 to 4 weeks before surgery to shrink down the liver, decrease the amount of fat around the stomach. It makes the dissection in the field maybe a little bit easier to visualize. So this is a trick that I've started doing in my reflux clinic. If I meet someone with a BMI of 30 who wants a different type of foregut operation, I'll put them on this diet as well. And maybe it helps, maybe it doesn't, but that's a trick to try. Some things to consider. So if you're talking to a patient who's pretty adamant that they don't want bariatric surgery and they are morbidly obese and they do have achalasia, In the discussion about the downstream implications of just doing a Heller, it's important for you and your patient to remember that if they elect to undergo a bariatric operation later in life, that's going to present some challenges, right? You may have to take down a fundoplication, or if you elect not to do one, which the data does not support, the patient's going to have lifelong reflux that may be very problematic. So it's important to think these things through, verbalize them with your patient, inform them, respect their decision, and then POEM potentially is a interesting entity to sort of put into this space, or pneumatic dilatation. POEM we've heard about earlier, but just some attractive things when you're thinking about this for morbidly obese patients in conjunction with or without a bariatric operation is it does allow for some staging. If your patient says no and then later may say yes, it makes your life a little bit more technically easy. There's a preoperative process that people go through before a bariatric operation that's educational. They meet with nutritionists, they have a psych eval, and this permits time for that. If there are insurance issues, again, you're not burning a bridge. And the operative, the redo field, if you do a POEM, I'd be curious to hear from people that have actually operated in this space, but a lot of the authors in these case series here profess that technically it's potentially a lot easier. Combined laparoscopic Heller myotomy and Roux-en-Y gastric bypass. I think I was listening to a talk by Dr. Hutter earlier in this meeting where he was bemoaning the lack of data for revisional surgery. And I think for this problem, there's an even greater paucity. So all of these things are case reports of 1 or 2 patients. But to me, in reading all of these case reports, I think this makes the most sense. So gastric bypass is a great operation for reflux. Heller myotomy is a wonderful operation for dysphagia. You combine the two, your patient should feel better. They're going to have durable weight loss. I think, as Dr. Morrow was saying, it's important to give them some anticipatory guidance. You're not curing their disease, you're palliating it. But this makes a lot of sense. Some pearls from this Facella chapter and also from Dr. O'Rourke, who published on one of these cases. So some things to think about if you're doing a gastric bypass combined with a myotomy is really planning the length of that myotomy with some precision. So intraoperative endoscopy is very nice here, precisely identifying the gastroesophageal junction, because you want to avoid making a really long gastric pouch to encompass your myotomy. You don't want your patient to have ulcers. But you also don't want to make a pouch that is so short that you've created inadequate myotomy and then you don't have a cuff of full thickness gastric tissue with which to fashion an anastomosis. So there's some technical thought that goes into that. There are a variety of ways to do a gastrojejunostomy, and it's worth pointing out that if you're someone that likes a vertical stapled kind of oranger technique, or if you do a transoral introducer or circular stapled technique, you don't want to be bringing that down through a myotomy or abutting it with your myotomy. So you may want to change your technique, or you may want to do the bariatric part of the operation first with endoscopic measurements to plan your myotomy and then follow that. Some other things that are out there. So a few people have written about sleeve gastrectomy, and I have a little bit of trepidation about this. I think sleeve, wonderful operation, great weight loss. There's a lot of dialogue about the long-term reflux implications of this operation. And I think, unlike POEM, the thing to really remember, putting my bariatric hat on and then putting my reflux hat on top of that, is that we're eliminating the fundus, right? So you are, if you're doing a conventional sleeve, taking out that portion of the stomach. And there are some unconventional sleeves. There's a picture here from a patient I saw in clinic who had reflux, and they had a sleeve, and they left the proximal fundus, and they did kind of a door. And over time, that became very problematic. The sleeve was restrictive distally. The fundus blew out, and food's getting caught in that blind-in pocket that my yellow arrow is going into. So be careful about burning bridges. It's also important to remember, as a couple of panelists mentioned here, that we're really palliating this disease, right? There's a small but real risk of malignancy associated with achalasia. And occasionally people need revisional surgery. And so taking that conduit out may not be the best thing. Biliary-pancreatic diversion, some similar thoughts, excellent weight loss, maybe some disadvantages of the sleeve. But then another concern that's raised is this is a somewhat malnutritive operation. And if we're doing this in a patient with a swallowing disorder who's already at risk for malnutrition, is that the best option for the patient? So suffice to say that I think these are patients that are definitely worth discussing with colleagues, no matter which hat you wear in your practice, and talking about in multidisciplinary conference settings before undertaking them. It's also worth noting that in researching this talk, I actually found a fair amount of case reports about achalasia after bariatric surgery, which is something I hadn't considered when the topic was given to me. I think for achalasia after bariatric surgery, things number 1, 2, and 3 are really, think about pseudo-achalasia. This is very well described with the lap band. But we see it with sleeve, people with tight strictures and subjective dysphagia. If you get manometry on these people, they're going to have EGJ outflow obstruction. They may have abnormal studies, and depending on how long that's been going on, it can be a little bit confusing. For gastric bypass patients who present with dysphagia and reflux, you have to think about the gastrojejunostomy. Do they have an ulcer or stricture there? Is there a hiatal hernia with a pouch in the roux limb in it? So thinking like a bariatric surgeon, putting on that hat, and then if you really do a thorough evaluation, you rule out those causes, your diagnostic evaluation, your manometry is pretty characteristic. Again, think about making an adequate extent of the myotomy onto that bariatric operation or reoperative field. This is also maybe a very nice space for POEM. So in summary, achalasia is a real entity in obese and morbidly obese patients. And when we meet these patients, I think we should wear all of our hats, really listen to what they're telling us historically, do a careful preoperative evaluation with attention to their symptoms, a good diagnostic evaluation. Really, look at your manometry, look at the tracings, look at them with a reviewer in gastroenterology who's experienced, a colleague. Patient autonomy is important, so it's not really fair to say no to these people if they're not comfortable with bariatrics and they have profound dysphagia. I would vote for gastric bypass as the bariatric of choice, given the extant data to be combined with a Heller myotomy. And then POEM with or without subsequent gastric bypass is also a promising option. Thanks very much for the opportunity to speak.